My dear friends Alba, Bridget, Carol, Irene, Oksana, and Rosemary, and my cousin Nina all succumbed to cancer in their 40s and 50s. Each one of them wanted desperately to survive, and each was a cooperative patient who carefully followed the recommendations of her oncologist. I wish that there had been more to offer them all. I loved and respected every one of them. I watched their suffering, and I know they all deserved better. They are with me still. For them, and for Caroline, Joy, Lynn, Richard, Sherry, Susan, Tony S., and many others who shared their perspectives with me as cancer patients, let me be clear. It is time to transform the cancer culture as we know it. In 1992, I was a young doctor working as a radiologist in the outpatient mammography division of a leading teaching hospital. On any given day, our waiting room was filled with women scheduled for a routine screening mammogram. Among them were patients who needed a follow-up scan because a previous one had shown an abnormality. Others were there because they had felt a breast lump, or their doctors had. Occasionally, a man came in for a mammogram, reminding me that approximately 1% of all breast cancers occur in men. There was always an undercurrent of anxiety in our department, even among the women who were just getting their annual test. Everyone, patients, family members, and doctors, knew that the results of the test could change a person's life in an instant. Understandably, women who had already been treated for breast cancer were the most apprehensive. Nothing was routine about their tests. We were looking for any sign to suggest that the disease had returned, and their fear was almost palpable. That was the situation of a 48-year-old woman I'll call Mrs. Thompson. 2 years earlier, she had undergone surgery and chemotherapy for cancer in her left breast. The following year, she received the grim news that the cancer had recurred, and she underwent another operation. Now, 6 months post-treatment, she had come for a follow-up mammogram at the hospital where I was working. Her husband accompanied her, and from the moment I met them, I could sense their worry. Mr. Thompson especially was tense and belligerent. Almost immediately after we introduced ourselves, he told me that his wife had been through the mill and that they had had just about enough of visits to doctors' offices. At that point in my career, I was a seasoned professional, a board-certified radiologist. Not only had I been well-trained, but I had attended conferences on mammography conducted by world-class, highly respected experts. I understood the science, but I also understood the fear. I tried hard to be patient, sensitive, and empathetic in my interactions with people facing so much uncertainty. It was my goal to treat patients just as I would hope to be treated myself under similar circumstances. From the beginning of my training, I had been mentored by very attentive and careful radiologists. These doctors always communicated directly and kindly with each patient before they left the mammography room. In most cases, they were able to say that their initial review did not indicate any suspicious findings, while emphasizing that they would review the mammogram more thoroughly and send the final report to the referring physician. Those were the happy times, when the patient would smile gratefully and thank the doctor. More challenging situations arose when the patient's mammogram did show something abnormal. That's when we needed to draw the utmost from our training and apply our best communication skills and sensitivity. In those moments, I realized that being a really good doctor, a doctor who was effective at communicating with the patient and protecting her interests, had more to do with what I had learned from family, friends, colleagues, and life experiences than with anything I had been taught at medical school. My mentors were always honest and compassionate in those circumstances. They would look the patient in the eye and tell her that there were a few findings on the mammogram that required further evaluation and follow-up. The term they would use was suspicious for malignancy. They would never say cancer, because a mammogram cannot prove that something is cancerous. It can only point to a suspicious finding that requires further evaluation. Still, when a patient heard the word malignancy, she would often begin to cry. I became painfully familiar with the look of anguish and the unanswerable question that typically followed. How could this happen? Sometimes a woman would say, "No one in my family has breast cancer," or, "I always come for checkups and I follow my doctor's advice." It was as if we were telling the patient that she was being punished for misbehavior. Other women had a less overtly emotional response. Instead of tears, some met the news with stoicism and silence. yet their pained and downcast eyes.
To keep listening to this audiobook, I've left you a link in the description so you can do it, at no cost thanks to Audible's 30-day free trial.